but postpartum weight retention, it is 0.0001, that is significant. Therefore, the impact of physical activity gestational weight gain reported in the present study far found with consistent with the previous literature. And when we talk about the physical activity, that is step count, we measure from 4th month to 7th month. Average step count was 4,500 to 5,800 from 4 to 7 month. But from 8th to 9th month, there is a sudden significant increase in the step count. It may be because of their concern of having normal or complication-free delivery, them to be more physically active during the last trimester of their pregnancy. It can be conclude that supervised exercise session is an effective approach to reduce excessive postpartum weight retention. And with that, use of pedometer with text message can also be used as a motivational tool along with exercise to increase the level of physical activity in pregnant females. These are the references. Thank you.
Okay, should I start with the questioning?
Yes.
Yes, ma'am.
Okay, so the first question is, why did you excluded the overweight more than 30 BMI? Because as per the weight gain chart, you have seen that the the least weight the woman should gain is in obese individuals, right? But then you have omitted them. So the normal BMI population should be gaining the average weight gain, so that that doesn't actually affect the behavioral changes also. So why did you omit the obese?
Ma'am, we have included normal BMI, overweight, and obese. We have excluded the BMI more than 30. That is over obese patient.
Over obese,
Obese.
more than 30.
Yes, ma'am.
Otherwise, you
Yes,
have
ma'am.
included all others, right? Less than
Obese.
30.
Yes, ma'am. Yes,
25
ma'am.
to 24 to 30 all. Fine.
Yes, ma'am. Yes, ma'am.
Second question is, you have given the intervention of once a week with the supervised exercise, moderate intensity exercise.
Yes, ma'am.
Is it that indicative for getting the statistical significant change? Still you got it, but still, what is the reference of doing that?
We have taken 4 exercise supervised exercise session per month, and they are advised to attend at least 3 exercise sessions so that the efficacy of the exercises, and after that they are advised to follow the same exercises at home so that the efficacy of these exercises can be secured, and the pregnant females can be motivated to do these exercises. And they were on the telephonically on the so that if they face any problem they can ask me, or but supervised exercise session once weekly we was taken.
So were they doing any non-supervised exercise or home exercise or walking just a
Home,
little?
they were provided with home exercises regime as they were doing in the supervised exercise session, at least 30 to 40 minutes with they were also advised to do walk at least 20 say 30 minutes walk, so that we are instructed, we are advised the effectiveness of these exercises as well as walking program, so that they feel motivated to do these exercises. And in our study it shows that both supervised exercise sessions and pedometer plus text messages both are effective, but supervised exercise session is more effective as comparison to pedometer plus text message, Guru.
Okay. And second question was this like you have evaluated the behavioral changes, right?
Yes,
okay.
ma'am.
So what was your outcome, the first outcome?
Gestational weight gain, ma'am.
And second?
Postpartum weight retention and anthropometric measures also, ma'am.
Okay.
So
there was nothing which included any behavioral changes or any subjective outcome which actually evaluate their intention or their inclination towards doing exercises or towards
Ma'am, we have included pregnancy physical activity questionnaire also. In that, in
What are the
subjective tool, in
components
that
of that?
components are they are doing light activity exercises, moderate activity exercises. There were sedentary activities. There are transportation activities. There are sports and exercise activity. All questionnaire included 36 questions. We take out that questions from second trimester and third trimester. From second to third trimester, the activities was increasing more of light intensity and moderate intensity. They are not go with vigorous exercises. And for supervised exercises and pedometer group,
See,
they
that
will
I
do
got
more.
it from your result. I
Yes, ma'am.
am asking you whether there is any change in the behavior of doing
Yes, ma'am.
exercises
Yes,
in
ma'am. Yes,
all
ma'am.
this group.
Yes, ma'am.
That's what I was
Yes, ma'am. Yes, ma'am.
asking.
Ma'am, when will? Okay. Thank you,
I
ma'am.
got that. That's
Very
all
good
from
morning.
my side.
Very good morning. It
Good
was
morning, ma'am.
indeed a good presentation. I have a
Thank
few
you, ma'am.
questions here.
Yes,
First
ma'am.
was that in the title itself, you're talking about it's a randomized clinical trial, but you did not
Yes,
mention
ma'am.
anything about the method of randomization which you use. So can you please
Ma'am,
elaborate on the method of randomization used by you?
ma'am, computer generated random table.
And how was it proceeded?
Ma'am, there is both are there, the cheat system and the computer generated random table, where we have when we have patient subject pregnant female came to us, then we have number generate one research assistant that is not included in the study. They basically assign that particular group, so that as the intervention suggests, because we are giving the exercises protocol, so investigator was not blinded. So, but the research assistant were used for that particular looking the numbers from group 1 to group E, that is from control to pedometer plus text message group.
No, but whether it was computer generated or chip method, you are saying both. How can it be both? It can be one. So
Ma'am,
either it was,
basically it is computer generated number, ma'am.
and how was that done? By a blank envelope method or by a
Ma'am,
block
black
method?
envelope, by black envelope, ma'am.
And the duration of the study was March to August.
Sorry, ma'am.
The duration of the study was from March to August, which is approximately 6 months. So you were able to complete the trials.
More. No, ma'am. March 2019 to August 2020, ma'am.
The title itself, you're talking about behavioral change, but none of the the interventions which you gave or the outcome measures talked about behavior. So why did you use the term behavioral change? Why not just intervention of exercise therapy?
Because, ma'am, we have used text message also, so we are going to assess whether if we give text message based intervention only, then it will affect the behavior of the pregnant female. If they were motivated to do that particular exercises and other things, it may be related to their general health, it may be related to their nutrition related component. So, and in pedometer group, they were advised to wear a pedometer and go for the activity, that is step count. At least they have to follow the 5,000 steps. So those pregnant female who follow the instructions, at least though have attended the 5,000 steps, they will gain less gestational weight gain, and after the pregnancy delivery, they also
But that
have
is
the
all about,
less.
but that is all about intervention. I'm talking about behavior specifically. There was no outcome measure which talked about the assessment of the behavioral change which actually happened. The tool that the questionnaire that you're talking about is also a
That's
physical
what my
activity
question
questionnaire.
was. That's what
It's
my
also
question
just a
was.
physical activity questionnaire. It is not
Yes,
a
the pregnancy
behavior
test.
modification questionnaire. BMAC is a physical
Okay.
activity questionnaire. BMAC is not a behavior modification questionnaire.
Okay,
There
ma'am.
was no
So you are
tool which was used to assess the behavioral change. The intervention which you gave also was not a behavior, because there was no motivation given from your end. If there was a motivation happening, there was a regular discussion happening, then you can say that,
the
okay,
motivation were given through the text messages. That's why we are talking about the maybe there may be behavior change in text message group. They are motivating through the text messages. At least they will do something for their health. And in both pedometer group, they were also instructed, they're also motivated to do at least physical activity or step count of at least 5,000 to 7,500 steps. So they are motivating. And in pedometer plus text message group, they are instructed to do the step count also, and they were also instructed to follow the text message instructions also. So in combinations, the effectiveness is more as comparison to alone pedometer. So that is the motivational factor, both the text messages and the instruction to do the physical activity when they were meeting again and again, approximately once a week. When they were going out for their gynecologist for the checkup, they also meet me, and they after that we will assess and we will motivate that particular pregnant female.
Thank you.
Thank you.
Thank you, ma'am. I'd like to call our next presenter with code BCIPCON/S/02 with abstract effect of transcranial direct current stimulation in players with ankle sprain.
Am I audible to everyone?
Yes, ma'am.
Yes, you are.
Is my screen is visible?
Yes. You can make it full screen
Okay.
or play the video. Yes.
Okay. Very good morning to all of you. The topic of my presentation is effect of transcranial direct current stimulation on pain, range of motion, and balance in players with ankle sprain. Ankle sprain is the most common sports injury, and lateral ankle sprain is the most common type that affects almost 30% of active people and sportsmen. About 40% of patients report of repeated bouts of the ankle giving away and recurring sprains, or the feeling of unstable ankle joint following the initial sprain, which is commonly known as chronic ankle instability. This injury causes deficits in the excitability of the cortex and can influence the functional ability of the individual. The studies has also shown that there is a decreased spinal reflex excitability in the soleus and fibularis muscle in the patients with chronic ankle instability. There was also decreased muscle activation and there were increased antagonistic muscle activity in patients with chronic ankle instability. The conventional treatment of ankle sprain focuses on the peripheral neuromuscular function, and often the most important sensory motor component is ignored. However, the spinal and the supraspinal elements play a very vital role in the regulation of sensation and balance in players with ankle sprain. Cortical changes in the chronic ankle sprain are a result of long-term effect of the injury. However, till date, no study have explored the cortical changes in the acute ankle sprain patients. So the use of transcranial direct current stimulation, which is a non-invasive brain stimulation technique, is known to have a neuromodulatory effect, which is explored in various neuromuscular and musculoskeletal conditions. Various studies has also described that there is an increase in the hip range of motion and decrease in the pain perception with the application of a nodal TDCS over the dorsolateral prefrontal cortex in normal healthy subjects. There were also increase in range of motion at the ankle joint after the application of cathodal stimulation over the CZ area. Therefore, the treatment intervention that has the potential to modulate the pain and improve the range of motion can be of great significance in improving the physical function in players with ankle sprain. Previous researchers has focused on exploring the effect of TDCS in chronic ankle sprain patients and in patients with chronic ankle instability. Until date, only few studies have explored the effect of TDCS in patients with acute ankle sprain. Therefore, the present study was undertaken with the aim and objective to estimate the effect of TDCS on pain, range of motion, and balance with players in acute ankle sprain players. Moving on to materials and methodology, the study was a randomized controlled participant blinded trial, and the necessary ethical approval were taken from the Institutional Ethical Committee, and the study was done according to the Declaration of Helsinki 2013, and a written informed consent were obtained prior to participation in the study from the participant. The study was also registered in Clinical Trial Registry of India, wide this number, and the sample size estimation for the study was based upon the findings of the two studies that suggested of n is equal to 20. And now the participant in the procedure, players with a history of ankle sprain with a duration of less than 2 months was screened by convenient sampling method. And the inclusion criteria for the study was the player with a history of ankle sprain in the last 2 months shall have no orthopedic deformity, able to read and write the Indian English language, and were willing to participate. The inclusion criteria for the study included ankle sprain of more than 2 months duration. The participant should have no history of epilepsy, no recent fractures, no arthritic condition, and deformity of lower extremity. This is a consort flow chart for the study. We screened the participant n is equal to 28 for the eligibility in the study, and have excluded 8 number of participants. 4 participants did not meet the inclusion criteria, 2 declined to participate, 1 was contraindicated to injury, and 2 participants discontinued the participation before the randomization procedure. So we have randomized 20 participants and were allocated to 2 groups, group A and group B. Group A was active TDCS group and group B was sham TDCS group. And group A, participants in the group A received active TDCS for 2 milliamperes for 20 minutes for 5 consecutive days. And in group B, participant received sham TDCS for 20 minutes duration for 5 consecutive days. And analysis of n is equal to 10 was done in group A and 10 in the group B. The outcome variables for the study was the pain was analyzed by using a visual analog scale. The range of motion was analyzed by using electrogoniometer, and the balance was assessed by a Y balance test, which is based on the star excursion balance test. 3 valid measurement of Y balance score and range of motion was done by 2 independent assessors to augment the reliability of the data. The data analysis was done by using SPSS version 21, and the normality of the data was checked by using Shapiro-Wilk test. Unrelated t-test was used for between group comparisons, and related t-test was used for within group comparison of each outcome variable. For assessing the differences in the pain, Mann-Whitney U-test was used for between group comparisons, and Wilcoxon sign rank test was used for within group comparison, and the significance level was set at p less than 0.05. Now, let's discuss the results. No significant differences in the age, height, weight, injury duration, leg length in the participants of the study between the group was seen. And we have 14 male and 6 number of females in the study. There was a significant reduction in the pain when the between group comparisons were done, and the within group comparisons also found to be statistically significant in both the groups. There was a significant improvement in range of motion also in the dorsiflexion and in plantarflexion when the between group comparisons were done, whereas there was no significant between group differences was found in the balance, which was assessed by Y balance test. The within group comparisons of these 2 variables showed significant improvement in balance in the dorsiflexion range of motion and Y balance score only in the group 1, and no significant differences in any of the outcome variables were seen in group 2. Now, moving on to discussion, for the pain, there was a significant improvement in pain. This can be because of the pain modulating effect of the TDCS, which was also reported in various musculoskeletal conditions such as chronic low back pain, fibromyalgia, and knee osteoarthritis. The possible mechanism for this modulation of pain can be because of the suppression of the nociceptive inputs from the injured ankle joint by the stimulation of motor cortex that have inhibited the repetitive firing of neuron and have induced neuroplastic effects in the brain. Similar pain modulating mechanism that is also seen by the stimulation of motor cortex that showed suppression in the nociceptive neurons and inhibition of the burst firing of neurons in the damaged area of thalamus and have induced a neuroplastic effect in the thalamus. Also, another study has shown that the upregulation of the excitability of motor cortex modulates the pain perception directly as well as indirectly on pain modulating areas such as thalamic nuclei and cingulate gyrus. There can be a pain modulation because of the use of typical montage that is placing the node on the dorsolateral prefrontal cortex and cathode at CZ for 5 consecutive sessions. The similar placement of electrode have also shown significant reduction in the pain perception and improvement in range of motion in healthy normal subjects. Various studies have also applied TDCS for 5 consecutive sessions and have shown significant reduction in pain in conditions such as stroke, fibromyalgia, and knee osteoarthritis. The significant improvement in range of motion can be owed to the decrease in the pain that might have caused increase in the range of motion. Various studies has also shown that there is an increase in range of motion and decrease in pain perception at the hip joint with the application of anodal TDCS on dorsolateral prefrontal cortex in normal subjects. Another study has also shown the significant improvement in the ankle range of motion with the application of TDCS in normal healthy subjects. There was no significant improvement in the dynamic balance in the present study because the present study has only explored the effect of TDCS and has not given any kind of exercises for ankle sprain patient. So this can be one of the reasons for no improvement in balance performance in players with ankle sprain. Whereas studies that have used the combined application of TDCS.
Completed, dear author.
Okay, so
8
just give
minutes
me
are
2 minutes.
submitted.
Yeah, I'm just one slide is left. The possible mechanism, the other studies that have used the combination of TDCS with food exercises have shown significant improvement in dynamic balance in patients with chronic ankle instability. The limitation of the study is small sample size, extraneous factors such as nutrition, hydration, previous activity level, lower body strength were not controlled. And the strength of the study is this is the first study that have determined the effect of TDCS on pain, range of motion, and balance in players with ankle sprain. And the future scope can be the further researches on large sample size and the use of TDCS along with the food exercises that focuses on improving the proprioception and balance can also be done. And the implication in physiotherapy it can be the application of TDCS is easy and cost effective. So it can be it can be of potential, it can be seen as a potential intervention to reduce pain and improve the range of motion in players with ankle sprain. So it can be concluded that the application of TDCS is an effective approach in decreasing the pain and improving range of motion, but has shown to be ineffective in improving balance in players with ankle sprain. These are the references. Thank you so much.
Respected
my-
judges, the presenter has exceeded the time limit. So do you have any questions, ma'am? Judges?
We have question, but are we having the time to ask because we have split
Yeah, sure, ma'am.
question
If you want.
answer? Okay. So first question is how did you included ankle sprain patients, because what did you include into ankle sprain? Was it ligamentous injury grade 1, 2 only? Was there the injuries which requires any immobilization and then you gave it into rehabilitation, or it is just a grade 1 where the patient is not been bound for the immobilization? Like I wanted to know the inclusion criteria and the exclusion criteria.
Yes, ma'am. Yes, ma'am. We have visited many sports schools in the city and the nearby areas, and the players were asked for having any history of ankle sprain and were screened for the inclusion criteria. If the player reports of any history of ankle sprain of less than 2 months, they were screened for inclusion. And in the inclusion criteria, we have asked the patient whether they have ankle sprain or not. And on the assessment, if they, we have only included grade 1 and grade 2 ankle sprain, and have excluded those patients who requires mobilization, because the players who require mobilization are not very cannot perform Y balance tests and all. So we have excluded those.
That I understood, but why this question arises because you have included the outcome measure as range of motion. So
Yeah.
if you consider it as grade 1 where they are ambulated, not having much, so in that kind of patient, the major complaint is pain, not the range of motion.
Right.
So that's where the question arises. If you consider the patients who are having the restricted range of motion, then it may be the patients might have given the immobilization, or it may be the higher grade of injuries.
Right.
So both are contradictory with your intervention or inclusion rather.
And we have only included grade 1 and 2 patients, and grade 3 were excluded.
And second question is, we'll go short. Second question is, how will you justify the effect on pain in group 2?
Sorry, I didn't get it. Can you please repeat the question?
In group 2, there was improvement in pain, right, within the group also.
Right.
So was that just a sham treatment? Means it was just placement, or you gave some low threshold electric current also?
Yeah, ma'am. We have applied, we have given the sham treatment, and we have applied the device. We switched it on for 30 seconds, and then the instrument was turned off. The patient, although there was no improvement in pain, range of motion, or any of the outcome variable in the sham group, ma'am. Even if we have done the within group comparisons, there were no improvement.
You said there was significant improvement in both the groups, but more in group 1, I guess.
No, ma'am. I can show you the slide, ma'am. There was, I have clearly told that there was no improvement in the group 2. See, ma'am, here is the slide. There were no significant differences in any of the outcome variables in the group 2 when the within group comparisons were done.
Go to the previous slide.
Ma'am, this was only for group 1. I was telling about the experimental group in this slide.
Fine. Okay. To the next judge.
Okay. So again, I have two questions. One was that you talked about there were two evaluators who were the who did the balance for the reliability. But how did you finally take out the readings for the balance? Did you take a mean for both of them?
Yes, ma'am. We have taken 3 measurements and we have found the average value for those measurements, and then we have reported.
That means 3 each. So total
Yes.
6 values and the mean of total 6.
Yes, ma'am. Yes.
For each participant.
Yes, ma'am.
And you said in your limitations the sample size was small, but initially somewhere you also talked about calculating the sample size. So if the sample size was calculated, then how was it small?
Ma'am, actually we have thought that we will include some more patients, but we kept on the basic level, because for the good analysis we must go beyond the sample size. Means that is the basic. We have found that the sample has to be at least 20, 10 in the each group. But we could not do it on more patients because of the COVID lockdown and all. So we have kept it on the basic level.
That means you did not include any dropouts. That's what you're saying.
No, ma'am. We didn't had any dropouts as such. 2 patients had already discontinued the treatment before the randomization because of the COVID positive report. So I did not face any dropout in 10 patients. 10 each.
No, I'm not clear of it.
Sorry.
You said 20 was the sample size.
Yes.
And 20 you recruited. There were no dropouts. So how was the sample size small?
No, ma'am. I was saying that you can see in this flow chart, we have screened quite a lot of patients, like 28 patients we have screened, and we have excluded 8 following the inclusion-exclusion criteria. Then we have randomized 20 patients, 10 in each group, and then we have found out only 20. The studies were saying that 20 is the sample size estimation based on the earlier 2 studies, but for a good interpretation of the results and for a very valid result, we must go beyond the sample size estimation. So I could only do 20 patients. That's all I can say.
In your conclusion, you were talking about something about it brought about an improvement in the pain.
Yes.
That's the only parameter that you talked about. But when you in your inclusion criteria, you have not taken care of the floor and the ceiling effects for the range of motion or balance or pain at all, because there was nothing in the inclusion criteria whereby you said that this is the minimum value of the balance that I want, or this is the minimum ROM that I want, or this is the minimum for the pain that I want. So whether the improvement happened or it didn't happen, you really don't know, because there was no difference that was spoken about.
Okay, this I forgot to mention, and in the next future work I'll take care of it.
Okay, that's all from mine. Thank you.
Thank you so much.
Thank you, ma'am. I'd like to call our next presenter with code BCIPCON/S/03 with abstract impairment of memory and stroke, a comparative study.
Good morning, everyone.
Good morning, ma'am.
Is my screen visible?
Yes, ma'am, your screen is visible. You can full
So can I start?
Yes, you can start, ma'am. You're audible also.
Good morning, everyone. The topic of my presentation is impairment of memory in stroke, a comparative study.
Ma'am, please full screen your presentation. Yes.
Yes, sure,
Full screen now, please continue.
Coming to introduction, according to WHO, that is World Health Organization, stroke is defined as rapidly developed clinical signs of focal, or you can say global disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than that of vascular origin. It is a brain attack which is caused either by reducing blood and oxygen flow to the brain or by bleeding. It is considered to be a major cause of long-term physical disabilities in adults, and the second most common cause of cognitive impairment and dementia, and third leading cause of death after coronary artery diseases and cancer. In case of stroke, one or more cognitive domains may be affected, including attention, memory, language, or orientation. Now coming to memory, it is the faculty of mind by which information is encoded, stored, or retrieved. Usually memory is known as information processing system with explicit and implicit functioning, which is comprised of a sensory processor, short-term or working memory, and long-term memory. Hypoperfusion and functional deactivation in neighboring and distant areas of brain are associated with cognitive dysfunction in acute stage of stroke. Memory impairment has been reported to be one of the most common cognitive deficits experienced by leftovers of stroke. Various scales can be used for assessment of memory and cognitive functioning in stroke patients, which are Wechsler Memory Scale Revised, Wechsler Adult Intelligence Scale Revised, Mini Mental State Examination, Scaffold Objective Recognition, Recognition Memory Test, Full Object Memory Evaluation, etc. So this study was carried out with an objective to find out impairment of memory in patients with and without stroke, and also to determine whether memory is related with gender and a stage of stroke, that is acute or chronic. Coming to methodology, the study design was survey. 80 participants were included in this, and the location was various hospitals. The outcome measure was postgraduate institute memory scale. Coming to methodology, 80 subjects, 40 with stroke and 40 without stroke, with age 25 to 85 years, fulfilling the selection criteria were included. All of them were told about the procedure of the study, and all their queries were answered, and informed consent was taken. Each subject was asked questions included in the postgraduate institute memory scale. Accordingly, scoring was done, and the data was later analyzed. The data was analyzed via SPSS. Coming to results, there was statistically significant difference in memory between stroke patients and normal subjects of same age, irrespective of type of injury to brain. There was insignificant difference in memory between acute and chronic stroke subjects. Insignificant difference was found when comparing memory in males and females suffering from stroke, but the significant difference was found in memory while comparing memory in males suffering from stroke when compared to normal individuals. Also, there was significant difference in memory when females were compared with stroke and without stroke. This is the table which shows difference in memory between stroke and normal population. 40 stroke patients were there and 40 normal subjects were there, with a mean of 55.6 plus 15.5 for stroke and 75 plus 14.4 for the normal patients. The results were found to be significant. In acute and chronic stroke subjects, the results were insignificant. In males and females, the results were found to be insignificant, while when compared normal males with stroke patients, male patients suffering from stroke, and female patients normal and suffering from stroke, the results were found to be significant. Coming to discussion, the aim of study was to find out whether stroke has any effect on memory. The results of the study support our hypothesis that there was significant decline in memory in stroke survivors, but no association of memory decline is seen in acute and chronic stroke survivors. Also, no significant association is seen with respect to gender in stroke subjects. A study performed by West Magott R concluded that children with unilateral neonatal stroke, particularly males, are at increased risk for emerging deficits in higher level cognitive skills during school years. A study performed by Tatemichi Tike concluded that cognitive impairment occurs persistently after stroke, often including memory, orientation, language, and attention. Cognitive impairment was most frequently associated with major cortical syndromes and with infarctions in left anterior and posterior cerebral artery territories. The wide categories of learning and memory are explicit and implicit. A study performed by Boyd A concluded that implicit learning and memory are not completely lost after stroke. However, as stroke intensity increases, it comes out that potential for implicit learning. The limitation was small sample size, and other tests could have been used to avoid bias. Also, different domains of the scale could have been compared. Coming to conclusion, The study suggests that stroke plays a significant role in affecting memory. So it is further suggested that along with medical and physical treatment of patients suffering from stroke, memory and retention should be given equal preference so as to make patient remember the activities and carry out functions of daily living smoothly. These are the references. Thank you.
Thank you, ma'am. Judges, please ask your questions.
Okay, no question from my side. Good study, simple and clear.
Thank you so much, ma'am.
Zubia, ma'am, do you have any questions?
Yeah, I have a few questions here. So I'm
Yes,
not a
ma'am.
neuro expert, so please excuse me if my questions you find them stupid. Okay, excuse me for that. But as you said in your discussion also that cognitive impairment was frequently associated, and most of the patients are already complaining of memory. So what was the need of the study when it was already established that there would be a decrease in memory in the subjects?
Actually, ma'am, we intended to find out what is the difference between normal and stroke population. What is the extent to which there is decrease in memory, actually.
But that did not happen. You did not find out the extent. You only showed that whether they were different or not.
Actually, ma'am, when we compared the data, we find out that the memory was significantly decreased, but we are yet to perform further analysis of further domains, which would establish that what are the domains which are particularly affected by a stroke.
Is that not dependent on the type of the stroke, the artery which was involved?
Actually, ma'am, when posterior cerebral artery is affected, it affects memory, right? So depends up to what extent memory is affected, whether it is short-term memory or it is long-term memory, or whether retention is affected. It is yet to be find out.
But in your study, you did not include the patients who only had a PCA involvement. Huh?
Yes, ma'am.
We had all the patients there.
No. All the patients were not only affected from posterior cerebral artery syndrome. Actually, that can also be considered to be a limitation, that we have included all the stroke subjects. There can be, you can say, we can demarcate that suppose only posterior cerebral artery syndromes are affected or medial cerebral artery, we can distinguish it in our further studies.
But based on one single question, how will you do all that? I see only one question which was done.
Well, ma'am, we can use other memory scales which are there to find out affection of memory and cognition in these patients.
I think your inclusion criteria was very, very weak.
Yes, ma'am.
I have a very weak inclusion criteria. So the conclusions, whatever you're talking about, I don't think we can give those conclusions at all.
Okay, ma'am.
It's a very weak study as far as the methodology was concerned.
Okay, ma'am.
Thank you.
Okay, ma'am. Thanks.
Thank you, ma'am. I'd like to call our next presenter with code BCIPCON/S/04 with abstract combined efficacy of neuromuscular exercise and neuromuscular electrical stimulation in the management of knee osteoarthritis case report.
Yes, ma'am. Good morning. Good morning, everyone. I'm audible to everyone?
Yes, ma'am. Please share your screen.
Yes, ma'am. Is it visible?
Yes, ma'am.
Good morning, everyone. My topic of presentation is combined efficacy of neuromuscular exercises and the neuromuscular electrical stimulation in the management of knee osteoarthritis. It is a case report. First of all, introduce with the knee osteoarthritis. As we all aware about that knee osteoarthritis, it is the most common arthritis of the lower limb, especially in the geriatric populations. Patients with the knee OA mainly presents with the pain, swelling, stiffness, and the disability, which imposes increased healthcare cost. Case presentation. My case is on a 50-year-old female that is suffering from the knee pain, swelling, crepitus, and the decreased range of motions and altered balance. Patient reported her knee pain 8 by 10 at the VAS scoring, that is visual analog scale, and the aggravating factors for pain were prolonged walking, ascending and descending stairs, and squatting, and the pain was relieved after taking rest intervals. Outcome measures for the study was VAS for pain, visual analog scale, and physical function and the knee-related quality of life by the KOOS, that is knee injury osteoarthritis outcome scale, and the balance impairment and the risk of falling in the patients by using questionnaire, dynamic gait index, and the community balance and the mobility scale. And the mobility skills were tested by the timed up and go test, and knee joint range of motion in both extremities was measured by the goniometer. The outcome variables were measured at the two intervals, at the baseline before starting of the treatment and at the end of treatment, that is at the 6th week. Diagnosis was confirmed grade 3 knee osteoarthritis as evident in the X-ray. Treatment protocol for this study. The treatment protocol comprises of 18 sessions, that is of 6 weeks, that is, it means thrice a week for 6 weeks, followed by the re-evaluation at the 10th week. The treatment protocol for the patients include neuromuscular exercises, which comprises various exercises in which there are forward and backward sliding or stepping. We can say that patient have to move forward and backwards in sliding manner, or he or she can stepping forward and backwards. And sideways exercises. These exercises are done in 3 sets with 10 repetitions. And functional hip muscle strengthening and the knee muscle strengthening. We can use various strengthening protocols in this functional hip strengthening and the knee muscle strengthening. These are done with the 2 sets with the 5 repetitions and the step up and step down. For the 3 sets with the 10 repetitions, and balance, that we can say that standing on the affected leg, or we can say that just weight shifting on the one another legs. And the next treatment is the neuromuscular electrical stimulation. It is the electrical stimulation which comprises of frequency, that is of 50 hertz, and pulse duration, that is of 250 microseconds, was applied over the quadriceps musculatures for about 20 minutes. At the results, we can suggest that after the treatment with this combined efficacy of neuromuscular exercises and the neuromuscular electrical stimulation in patients, there is a reduction, marked reduction in the pain of the patients that was measured on the VAS from as the patient startingly complained, that is 8 by 10. And after the treatment, that is about 18 sessions for about 6 weeks, it is decreased to 2 by 10 at the 6th week. Next outcome measure was the range of motion in both extremities, right and the left. Range of motion was increased from 90 degree to 102 degree in right leg and 1010 to 121 degree in left leg. And the knee-related quality of life, and both by the pain, symptoms, and the ADLs, that is the activity of daily living, sports, recreation, and the quality of life was improved from 42 to 78. And these are 5 subscales of the KOOS variables, which we can suggest that they all are increased respectively as shown in the figure. And false prediction by the dynamic gait index was also improved from 13 to 19. It is actually a questionnaire that comprises of 8 questions and having about total scoring is of 24. And if the patient having more than 90 or 20, we can say that patients have less tendency to fall. And if the patients having score less than 19, we can say that patients have more tendency to fall. After doing that, these exercises, the neuromuscular electrical stimulation and the combined efficacy of neuromuscular electrical stimulation, we can say that patients have less fall prediction as measured by the dynamic gait index and as shown in the figure 6. And the balance and mobility was improved, that is measured by the community balance and the mobility scales, that was also improved from 29 to 58. It is also a questionnaire which comprises of various questions, and initially at the baseline, patients having a score that is of 29, and after the 6 week of treatment and 18 sessions, patients shows marked improvement in the balance and the mobility, that is a score about 58. And balance and mobility was improved as shown in the figure. This is the community balance and the mobility scale, which suggests that patients have more mobility and the balance after the 6 week of treatment. Basic mobility skill that was measured by the timed up and go test. Initially at the baseline, patients have timing for about 21.4 seconds. In this, patients have to stand up and walk for about 6 meters and then again sit down, and then we have to calculate the time. And after the 6 week of treatment, a patient's timing for this timed up and go test was reduced. That is about 12.6 seconds. So we can say that if the patient's taken about 12 seconds or less than, then we can say that patients have high mobility skills. So after treatment of 18 session or 6 week, we can say that patients have improved timing for timed up and go test. So we can say that this combined efficacy of these exercises and the electrical stimulation is a foremost treatment for the knee osteoarthritis. Conclusion: patients responded well to both management, that is neuromuscular exercises and the neuromuscular electrical stimulation, and there was decrease in VAS scoring, visual and analog scaling, and improvement in the knee joint range of motion of both extremity, right and the left, and the KOOS scoring, knee injury osteoarthritis outcome scores, community balance, and the mobility scales, and the dynamic gait scoring, and the timings in the timed up and go test. By keeping in the view of the benefits of combined protocols of neuromuscular exercises and the neuromuscular electrical stimulation, we can suggest that we can use this treatment is feasible in the management of knee osteoarthritis. These all are the references.
Bhavna ma'am, do you want anything to be repeated? Because ma'am, I think. Bhavna ma'am, are you there? Bhavna ma'am? I think we have lost connection with Bhavna ma'am. Dubya ma'am, please continue with your.
Okay. Usually when you're having a case study, it is something which is very significant, which you want to discuss about or which was important. What was so significant about this case because of which you thought you should be presenting it?
Because in my case, patients is about more than 50 years or about exact 50 years. So we can say that at this age, patients have more symptoms presenting with the knee osteoarthritis, and this combined effective protocols can be used in this knee osteoarthritis patients. So we can suggest that this combined protocol can be useful or feasible in the future population.
But this is already an established protocol, NMES along with electrical stimulation.
No, ma'am, it is the first study. Actually, neuromuscular exercises are established. These two protocols are separately established in the knee osteoarthritis. Basically, NMES, it is used in ACL injuries, and the neuromuscular exercises are used in the knee osteoarthritis. But in my study, we can combine both electrical stimulation and the exercises. So we can say that this is the first, which we can say that electrical stimulation and the exercise therapies can be effectively used in the knee osteoarthritis.
There are 2 PhDs which have been done in my center on the same topic that you're talking about. NMES exercises along with electrical stimulation. I don't know how you say that it's the first study.
No, ma'am, NMES, it is single. It can be used with different exercises, not with the neuromuscular exercises.
The neuromuscular exercises and NMES, they have been combined together multiple times. If you go through the literature, there is a recent study which was published in Bodywork and Movement Therapies also from our center, which is on the same topic.
Okay, ma'am, I'll check.
Yes. Okay, that's all from mine.
My question, only one question from my side is, you have included patients with VAS skill 8 also, right? Am I audible?
Yes, ma'am, you are audible. Ma'am, we lost you in between. Do you want anything to be repeated?
No. It's really fine. It's really fine for me. I was having one question that she took the case which is having VAS skill 8.
Ma'am, actually, I'm not. You are not audible. Can you please repeat the question?
What was the VAS skill pre-intervention in your patient?
Ma'am, scoring was 8.
Yes.
At
so
the baseline.
that is
Yes,
the question.
Yes,
that is the question. When the patient is having 8 VAS score pre-intervention, that means the patient is in acute inflammatory phase, right? And the inflammation is so much that you cannot give exercises at the beginning. So did you take that precaution while giving intervention, and what was the duration of your intervention? Because I missed that part.
Actually, my treatment intervention protocol or time duration was about 6 weeks, and I have given 18 sessions thrice a week for about 6 weeks. So we can say that at the baseline, I have used some measures just like cryotherapy to reduce any inflammatory changes in this patient. So after that, we can use this neuromuscular electrical stimulation and exercises.
Okay, you didn't mention it in your methodology. Fine. Because if you see, then you cannot give any exercises in the patient who is having 8 VAS score at the pre-intervention stage. So first and foremost thing is, you, as this is case study, you will have to be very precise because this would affect your result.
Bhavna ma'am, am I audible to you?
Yes, yes.
Ma'am, is that it?
Hello.
Yes, ma'am. Do you have any more questions or
No, no,
that's
no.
it?
I said it is. That's all from my side.
Okay, thank you, ma'am. I'd like to call our next presenter, BCIPCON/S/05 with abstract effectiveness of a rehabilitation protocol post decompressive craniotomy for improved functional outcomes, a case report.
Good morning to one and all. Am I audible?
Yes, ma'am.
Okay.
When you're logged with I think 2 devices, so the sound is it's echoing. Please check on your end.
Sorry, sir, I was not able to hear you.
Actually, you are logged in with 2 different devices, I think, or there is some other device with you. So the sound is echoing.
Okay, okay. So just a second, I'll check.
If you have your phone or a laptop placed together, just please check it.
Sir, I am currently logged in via laptop, not with any mobile phone.
Please go ahead.
Okay, okay. Is my screen visible, sir?
Yes, your screen is visible.
Good morning to one and all present here. Today, we are gathered here for the third national annual conference of BCIPCON. My topic is effectiveness of a rehabilitation protocol post decompressive craniotomy for improved functional outcomes. First of all, what is decompressive craniotomy? Decompressive craniotomy is a widely used neurosurgical technique in which we include excision of a part of skull to prevent any or to treat any anomaly of the brain, usually hemorrhages or post RTAs. In terms of neurosurgery, craniotomy is being the first choice of surgeons over a century. Decompressive craniectomy or craniotomy is post-traumatic brain injury in patients, develops positive and survival symptoms in patients who are critical. It is estimated that every neurosurgical procedure is related to 12 to 24% complication rate. Now, physiotherapists, as in general, have been devised the work of, seeing the patients after they have developed complications. Neurosurgical procedures may lead to any of the complications of immobility or complication of unconsciousness, and physiotherapists are referred post development of those comorbidities. So my case description is we have applied physiotherapy on the patient strictly after the surgery. before development of any comorbidity. A 27-year-old male underwent an invasive TBI while falling from stairs, after which he was taken to a multi-speciality hospital and was referred to a neurosurgery department. He underwent right decompressive frontotemporoparietal craniotomy on the same day of admission and was transferred to the neurosurgical care ward. He was unconscious after the surgery, and post 2 days of surgery, his vitals were unstable. He was referred to physiotherapy due to secretions present at the chest primarily, but after having talked with the neurosurgeons, we decided that we should start the physiotherapy intervention from the very first day after his vitals become stable. Present history was unconscious post decompressive craniotomy, right FTP, with presence of unstable vitals for 2 days. His vitals at the starting were SpO2 92% at 5 liters of O2 humidifier, which was varying. Heart rate was varying between 98 to 102 BPM. The BP was 141 by 88 mm of Hg, which according to the neurosurgeons was a normal gesture, because they have noticed post craniotomy there are many cases who undergo hypertension, and respiratory rate was fluctuating between 18 to 22 beats per minute. There was no past history, there was no relevant medical and surgical history. Personal history was not at all relevant, and the socioeconomic status was middle class. Now, observation: the patient was unconscious. The attitude of the limbs on the left side was externally rotated, abducted at the hip, and plantar flexed at the foot. Tracheostomy was present. Central line was present at the subclavian vein. Oxygen support was at 5 liters oxygen through humidifier. Catheters were Foley's catheter present, Ryle's tube present, and the skin integrity was intact. This is the first day picture of the patient after craniotomy. Examination involved GCS examination, which was E2, VT, M2. The Rancho's Los Amigos scale level was 2. Sensory examination provided wincing present over the after pressing over the supraorbital notch. Reflexes were diminished, especially on the left side. Muscle tone was generalized flaccid, and diagnosis was hemorrhagic contusion with subarachnoid hemorrhage. These were the, as on the right side, you can see these were the muscle girths at arm, forearm, thigh, and leg on the right and left side, and the passive range of motion values. These are the pre and post scans. This is the pre-scan before the craniotomy, and this is post-scan after the craniotomy procedure. Problem list was chest secretions, reduced saturation, and complications post immobility. Our goals of providing treatment were facilitating the airway clearance, enhancing oxygen saturation, simulation of consciousness, and prevent muscle sores and muscle wasting. We have developed this physiotherapy intervention for 15 days after the neurosurgical procedure, just after the neurosurgical procedure, that is from the day 1. But since the patient's vitals were unstable for 2 days, we have gathered this from the day 3rd up to 15 days of intervention, continuous 15 days of intervention. This is a 60-minute protocol per day. We have included transcranial direct current stimulation, music therapy, coma stimulation, mechanical vibration, percussion, muscle stretches, suction, range of motions, positioning, and various sensory re-education techniques. The instruments used were, as you can see, we have used a TDCS machine, the vibrator, spirometer, and the placement of TDCS electrodes was according to 1020 EEG system. The TDCS was placed at the anode was placed at F3 over the left dorsolateral frontal parietal cortex, and the cathode was placed at FP2 over the right supraorbital region. Because there was a right-sided hemorrhage also, so we decided to go for right supraorbital region. Then these are the pictures while intervention, while brushing, which was included in coma stimulation therapy. This was while percussion, the assisted sitting, and assisted ambulation of the patient within the neurosurgery ward. Outcomes used were early functional ability scale. This is a very recently devised scale used to assess the functional domains of patients, which consists of the autonomic functions of patients, the orofacial functions, the sensory motor functions, and the cognitive functions. It is basically devised for neurological and neurosurgical patients post-traumatic brain injury. It has a variance of score between 20 to 100. 20 is the minimum and 100 being the maximum. And each point scale consists of 5 items. This is a highly valid and reliable tool recently being used. And the second outcome which we used was Glasgow Coma Scale to assess the level of arousal in patients post-TBI. The readings taken on the day first, that is day third after surgery, day first of the intervention, was EFA at 28 and GCS being 5, E2, VT, and M2. Post 15 days of intervention, the EFA was recorded to be 82 and the GCS was not applicable since the patient was ambulating. These are the references which I have included. Thank you. Hello, am I audible?
Yes, ma'am. Bhavna ma'am, Zubia ma'am, any questions?
Yes, I have one question. So you were talking about an early functional ability scale, and you said it's a fairly new scale.
Yes, ma'am.
So is the reliability and validity of the scale is already established?
Yes, ma'am. It is established in German language. It is established. The validity is yet to be proposed according to Indian population, but the reliability is already established.
So did you? Is it a German scale or it's an English language scale?
Yes, ma'am. It was a German scale. It was translated into English recently.
Okay. Recently in India?
No, ma'am, not in India. Recently, it was a Californian study which translated it into English.
And if it was such a new scale and not a very valid scale because it's not established yet, why did you still choose to take the scale? Why not some other function scale?
Because there is no particular scale which assesses which is primarily made for the traumatic brain injury patients and which uses all the domains of the, if we are talking about functional outcomes, it is not just about consciousness. It is about consciousness, sensory motor, abilities, cognitive abilities, and it utilizes all the parameters which could be studied in a traumatic brain injury patient. So that is why the reason for selecting this scale was its applicability and feasibility, which was depicted in the articles.
Okay, that's all from mine. Thank you.
Thank you, ma'am. Bhavna ma'am, do you have any questions? Bhavna ma'am?
Bhavna ma'am, you are not audible. I think we have lost connection with Bhavna ma'am. We'll wait for a few seconds and then we'll move to the next session.
Okay, it was a good study. It was good study, and I wish it should be implemented as a randomized control trial for the more patients so
Yes,
that we
ma'am.
can have a proper conclusion.
We are working on it.
Okay.
Thank you, ma'am. We'll move towards our next presenter with code BCIPCON/S/08 abstract, effectiveness of PEMF in different musculoskeletal disorder, a narrative review.
Good morning, everyone.
Good morning, ma'am.
Is I'm audible to all of you?
Yes, ma'am.
The screen is visible also. Please make it full screen.
Yes, sir. Now, is it okay, sir?
Yes, please continue.
Okay, thank you, sir. So the topic of my presentation, paper presentation, is effectiveness of PEMF in different musculoskeletal disorder, a narrative review. PEMF means pulse electromagnetic fields. Now, the rate of disability adjusted life and deaths due to various kinds of musculoskeletal disorders is increasing according to the data achieved from the Global Burdens of Disease study, which was conducted through 195 countries and territories from 1990 to 2017 based on the age, sex, and demographic index. There were about 1.3 billion prevalent cases and 121.3 thousand deaths and 138.7 million delays because of musculoskeletal disorders till 2017. The incidence rate of musculoskeletal disorders was found to be higher in females than in males and was found to be increased with increasing in age. The globally percentage of prevalent cases according to different kind of musculoskeletal disorders in year 2017 was greatest for low back pain, which was about 36.8%, followed by musculoskeletal disorders 21.5%, OA 19.3, neck pain 18.4, gout 2.6, and RA 1.3. The burden causes by the musculoskeletal disorder was found to be higher in developed countries. In 21st century, the magnetic therapy and electromagnetic fields have emerged as an effective physical means of management that are alleviating the numerous health issues, even when conservative way of management has failed. The magnetotherapy offers a comfortable and hazard-free method which precisely act on the site of injury, work on the main causative factor of the pain and inflammation, and on different type of disorders and their pathologies. Millions of individuals throughout the world have got benefit in managing various disorders of musculoskeletal system along with pain relief by the magnetotherapy. Pulse electromagnetic fields are one of the significant modality in the magnetotherapy. Now, methodology, we included English journal articles that focused on the various musculoskeletal disorders managed by PEMF. A database search was conducted using the following sources: PubMed, Google Scholar, Cochrane, and Scopus. The main clinical applications of pulse electromagnetic field are in the osteoarthritis. Osteoarthritis is a common condition of aging that extremely influences the quality of patient's life. Knee joint is most frequently affected, and OA knee is one of the major cause of disability in old age. Numerous treatments are available for the management of OA knee, comprising of non-pharmacological management. Anti-inflammatory drugs are lastly total knee replacement for the advanced cases of the OA knee. The role of pulse electromagnetic field in the management of knee OA persists controversial. Newest studies verified that pulse electromagnetic field as a beneficial complementary management possible for treating the knee OA. Then it is also used in chronic mechanical neck pain. Chronic mechanical neck pain is a non-specific disorder of general population. Mostly it is aggravated with movements of the neck and is resistant to common therapeutic interventions. This condition influences approximately 45% to 54% of population at some phases of their lives and causes severe discomfort, pain, and disability. A randomized control study suggested that pulse electromagnetic field at 5 to 25 hertz of frequency and about 70 microtesla intensity twice a day for 2 hours for 8 weeks does not show any considerable effect on the reduction of the disability and pain, which was the result of this study. Then it is also used in the shoulder impairment syndrome. Shoulder impairment syndrome frequently produces pain in the upper extremity and cause reduction in the function of this joint and decline in quality of life. It influences almost 20% of the population and its incidence increases with aging. As the chief complaint of patients suffering from shoulder impingement syndrome are stiffness, joint pain, and functional deficit, non-surgical management are concentrated on relief in symptom and enhanced functions. A randomized control study recommended that combination of pulse electromagnetic field at 50 hertz and frequency, then 20 microtesla intensity for 30 minutes, 3 sessions per week for 3 weeks, along with the exercise of shoulder, can helpful in recovery of functions, muscle strength, a decrease in pain in patient with shoulder impingement syndrome. But the outcomes of pulse electromagnetic field in the shoulder pain patients are presently controversial. Now, the fibromyalgia. Fibromyalgia is a long-lasting pain condition generally seen in female and illustrated by extensive muscle pain, fatigue, tenderness, non-refreshing sleep, and additional related symptoms. The exact cause and pathogenesis of the fibromyalgia is not clearly understood, however, may include abnormal level of neurotransmitters in the peripheral and central nervous system, poor regulation of hypothalamic pituitary adrenal axis, nitric oxide, and oxidative stress. Subtyas et al. Found that when pulse electromagnetic field applied at the frequency of 0.1 to 64 hertz and intensity of 4 microtesla and for about 30 minutes twice a day for 3 weeks improves the pain, weakness, and overall functional status of the patient with fibromyalgia and could offer a possible beneficial adjunct to present fibromyalgia therapies in the future. Then in the hand, osteoarthritis is very common joint disorder which influences almost 15 to 20% of adult population, including wear and tear of the cartilage, which leads to painful joint movements. Osteoarthritis of the hand is seen in approximately 80% of the aged females, and maximum involved joint are distal and proximal interphalangeal joint of second and third finger and carpometacarpal joint of the first finger. Kanat et al. Evaluated the effectiveness of magnetotherapy in hand osteoarthritis. In this study, the treatment group received magnetotherapy with flux intensity of 3.5 to 25 microtesla and 450 pulse per second and 5 to 80 Gauss 20 minutes per day for 10 days conjointly with hand exercises, and the control group received the sham magnetotherapy for 20 minutes per day for 10 days conjointly with the same exercises. Quality of life and pain and SF-36 scale was found to be better in the treatment group. Then in low back pain, sciatica usually occur due to intervertebral disc herniation of lumbar region. It is one of the most common reason of radicular pain. Maximum number of patients are treated conservatively, while considerable minorities undergo disectomy. Limited investigations were carried out to assess the efficiency of pulse electromagnetic field in conservative management of low back pain, and initial results revealed favorable outcome in patients of lumbar disc herniation with or without radicular symptoms. Omar et al. Found that pulse electromagnetic field, if given at frequency of 7 to 4000 hertz at intensity of 5 to 15 Gauss for 20 minutes once a day for 3 weeks, is an effective means for conservative management of lumbar radiculopathy caused by the lumbar disc prolapse. Then patellofemoral pain syndrome is very common condition that.
Sorry to interrupt, but your time is up.
Okay, ma'am. I'm just concluding it. We can use it in low back pain, then patellofemoral pain syndrome. PMF is found to be very effective in non-union of fracture in cases of osteoporosis, in cases of osteonecrosis. Then in other condition also, it is revealed to be valuable in the management, like in lateral epicondylitis, then disc degenerative diseases, other musculoskeletal chronic pains in nerve regeneration. Results, PEMF illustrates lot of possibility to become a separate or complementary management method for treating various musculoskeletal conditions due to its high efficacy and minimum risk factors. Limitations and undesirable effects of the PEMF are that PMF causes any hazards to well-being operators and patient in clinical use. Several safety exposures guideline and specialist view from competent organization have specified that exposure to electromagnetic field can cause harmful effects to the brain and peripheral nervous system, cardiovascular system, cognitive and vestibular function. So conclusion is based on the positive findings of the available literature. Pulse electromagnetic field illustrate lots of possibility to become a separate or complementary management method for treating various musculoskeletal conditions due to its high efficacy and minimum risk factors. To completely find out the effect of PEMF in managing various or different kinds of musculoskeletal condition, extensive clinical application, well-designed, high-quality investigations are required to know the deeper mechanism, standardized treatment parameter, and evaluation of the most advantageous protocols for application in various musculoskeletal condition is required. These are the references. Thank you.
Thank you, ma'am. Judges, any questions?
So I just want to ask about the inclusion of the literature which you have selected.
Ma'am, I have started just now reviewing the literature, and I have found out the literature from Scopus, from PubMed, and from Google Scholar. I basically want to know
Any
that
random.
in random sampling, yes, ma'am, random selection.
Any random literature you have selected, because it needs to be evaluated before you select for the any conclusion about any literature review. So did you do any Pedro rating for the literature?
No,
Because you are
ma'am,
going
I've
to
not.
conclude something about that.
No, ma'am, I've
something
not done
about,
any Pedro
intervention.
rating. No, ma'am,
Okay.
I've not done any Pedro rating. I just wanted to know that in which all conditions the PEMF is effectful in musculoskeletal disorders.
Okay. Done.
No questions from my end. Thank you.
Okay, ma'am. Thank you, ma'am. We'll
Thank you.
we'll move towards our next presenter with code BCIPCON/S/09 abstract physiotherapy management in benign paroxysmal positional vertigo, a systemic review.
Good morning, all of you. Am I audible?
Yes, ma'am. Good morning.
Okay. So my topic of presentation is physiotherapy management in benign paroxysmal positional vertigo, a systematic review. So vertigo is defined as an illusory sensation of motion of either the self or the surroundings in the absence of true motion. Positional vertigo is defined as a spinning sensation produced by changes in the head position relative to gravity. And BPPV is defined as a disorder of the inner ear characterized by repeated episodes of positional vertigo. So the term paroxysmal describes the rapid and sudden onset of vertigo initiated at any time by a change of position, thus resulting in BPPV. And it has also been termed as benign positional vertigo, paroxysmal positional vertigo, benign paroxysmal nystagmus, and paroxysmal positional nystagmus. It has basically one of two variants, BPPV of posterior semicircular canal, known as posterior canal BPPV, and BPPV of lateral semicircular canal, which is also known as horizontal canal BPPV. The posterior canal BPPV is most common than horizontal canal, constituting approximately 85 to 90% of all the cases. And it is the most commonly thought to be due to canalithiasis, whereas the fragmented otolith particles entering the posterior canal become displaced, causing inertial changes to the cupula in the posterior canal and thereby resulting in abnormal nystagmus and vertigo when the head encounters motion in place of the affected semicircular canal. The lateral canal BPPV accounts for 5% to 15% of BPPV cases, and the etiology of this condition is also felt to be due to presence of abnormal debris within the lateral canal, but its pathophysiology is not as well understood as of the posterior canal BPPV. The basic rehabilitation exercises that are given in this condition are Brand-Daroff exercises. Irrespective of the involved canal, the Brand-Daroff exercise can be given instead of or in addition to the head movements carried out by the healthcare professionals. These exercises do not provide an instant cure for dizziness. Instead, a more gradual improvement would be seen as the exercises are repeated for 2 to 3 times per day and continued until patients have experienced 2 consecutive vertigo-free days. In posterior canal BPPV, vestibular rehabilitation shows most effective treatment outcomes. In these exercises, patients are instructed to rapidly lie on their side, sit up, lie on the opposite side, and then again sit up. Each position should be maintained for at least 30 seconds, and these exercises are repeated serially 5 to 10 times a day until resolution of the symptoms. So the need of the study, the common non-surgical treatment of BPPV are repositioning maneuvers and habituation exercises. The most common maneuver among all these is Canalith repositioning maneuver or Apley's maneuver. There are abundant literature present on the effectiveness of Apley maneuver as a treatment for BPPV, but there is scarcity of literature on the effectiveness of band Durf exercises. During the literature search, we came across 2 articles that says that Apley maneuver and band Durf exercises are equally effective. However, the effectiveness of band Durf exercises are not well explained. The aim and objective of my study, this study is present literature review aims to gather the literature available on band Durf exercises in order to explore its effectiveness in BPPV patients. So this review was performed in accordance with the PISMA guidelines. The search was done in the month of June 2021, and the articles included were from inception till date. The inclusion criteria was the articles focusing on the physiotherapy management of the BPPV, articles that specifically use band Durf exercises. The search was restricted to randomized controlled trials performed in humans, and only full text articles in English were included. The exclusion criteria was articles not having any specific intervention, articles other than English language, and articles other than band Durf exercises other than band Durf exercises. So my search strategy was for locating the literature, PubMed, Cochrane Library, and Google Scholar was used. The search was done in the month of June 2021. For PubMed, the search terms benign paroxysmal positional vertigo or BPPV or vertigo and physiotherapy management with title and abstract were used. For Cochrane Library, search term benign positional vertigo or BPPV or vertigo and physiotherapy management were used. And for Google Scholar, the search terms benign paroxysmal positional vertigo or BPPV or vertigo and physiotherapy management were used. So in Cochrane, I found 370 articles. In PubMed, no article was found. And Google Scholar, 193 articles were found. So in total, there was 563 articles. The studies I excluded on the basis of exclusion criteria were on the basis of title and abstract. 314 studies were excluded. 43 were only abstracts. 91 studies were registered clinical trials. 5 were reviews and 18 were the duplicate studies. So the full text article assessed for eligibility criteria was 92 articles, and full text articles that did not meet selection criteria was 82 articles, and only 10 studies were included in the qualitative synthesis. So the first study was the strategies to prevent recurrence of benign paroxysmal positional vertigo. The study was done in 2005 by Janet Audrey Helminski et al. Study was conducted in patients with posterior semicircular canal BPPV. It included 116 subjects diagnosed with BPPV, and patients in treatment group were 43 subjects performed daily band Durf exercises, while patient in no treatment group performed no exercises. The study concluded that a daily routine of band Durf exercises does not significantly affect the time of recurrence or the rate of the recurrence of BPPV. The second study was effectiveness of treatment for BPPV of posterior canal, done by Helen S. Cohen et al. In 2005. Patients were randomly assigned in 5 groups: modified Canalith repositioning maneuver, modified liberatory maneuver, sham maneuver, band Durf exercises, and vertigo habituation exercises. The study concluded that liberatory maneuver, Canalith repositioning maneuver, and exercises are all effective interventions, and patient education plus the sham maneuver have, however, had some beneficial effects. The third study was particle repositioning maneuver versus band Durf exercise for treatment of unilateral idiopathic BPPV, a randomized prospective clinical trial. Done by Carlos Amor Dorado in 2012. This study concluded that particle repositioning maneuver is more effective treatment and as safe as band Durf exercise in the short term for unilateral and idiopathic BPPV, and it does not reduce the probability of recurrence in the 4-year follow-up period compared with the band Durf exercise. The fourth study was effect of a combined exercise intervention in management of BPPV, done by Ramanathan K. et al. In 2019. This study concluded that the addition of Cawthron-Cooksey habituation exercises along with band Durf exercise is more effective in the treatment of vertigo among posterior canal BPPV subjects. Next study is the evaluation of efficacies and recurrence rates of 3 self-treatment maneuvers for posterior semicircular canal, done by Yan Xing Zhang in 2016. Study concluded that modified Apley maneuver are more effective than modified cement maneuver and band Durf maneuver for patients with recurrence, but it could not reduce the recurrence rate. The next study is comparison of effectiveness of Brand of vestibular retraining and applique canalith repositioning maneuver in BPPV, done by Yasser Satin et al. In 2018. It concluded that both Brand of exercises and modified applique maneuver were almost equally effective in the treatment of BPPV. The next study is effect of applique maneuver and Brand of exercises on BPPV. A randomized clinical trial performed by Choi in 2020. Study concluded neither the applique maneuver nor the Brand of exercise has an immediate therapeutic effect in treating posterior canal BPPV, and clear classification of posterior canal BPPV should be required at the time of different pathology and different treatment response.
Sorry to interrupt, ma'am. Your time is over.
Okay, ma'am, I am concluding.
Okay, ma'am.
So 7 out of 10 studies were in favor of Brand of exercises, and have shown that it is the Brand of exercises is an effective maneuver in improving the symptoms of BPPV patients, but 3 studies disagree with the effectiveness of these exercises. So Brand of exercise has been specifically designed to reduce the symptoms in the posterior canal BPPV. There are very few studies that have included the Brand of exercises and home treatment of the BPPV. Present review included 10 articles in which Brand of exercises alone or in combination with other repositioning maneuvers were used. 3 studies supported the effectiveness of these exercises. 2 studies do not favor Brand of exercises completely, but they say that it is as effective as other maneuvers. And 3 studies in this review were there which do not favor the Brand of exercises. So it is concluded that Brand of exercises are an effective maneuver in improving the symptoms of the BPPV patients. These are the references. Thank you so much.
I would request judges if there is any question.
So, good systemic review, and the process you followed for inclusion of the articles was good, very systemic. But when you are presenting, there is a feedback from my side that when you are presenting this kind of study in some conferences where you are time bound, you will have to explain the last conclusion part which you explained should be more elaborately explained, not the articles, and you should have included the mechanism of your VDE, how does it affects the BPPV, and the negative part also, because the one who is attending this conference may get to know about the articles and all. They are available online, but you need to discuss about the mechanism much so that it is convincing for the others to actually execute this kind of intervention into the patients, right? Okay. So just a feedback.
Thank you so much, ma'am. I will take care next time.
Now, as for the systematic review that you said, did you do the Prospero registration for this study?
Yes, ma'am. I have, my registration is not completed, but I have started the procedure for Prospero.
But Prospero registration is supposed to be done before you start with the study.
Actually, this was done in my pre-PhD coursework. I have, that time I gathered the literature, and now I am doing the, I have registered for Prospero so that I can start my study, the protocol, I can start my protocol. This literature was gathered in my pre-PhD time when I was doing my pre-PhD coursework.
What I understood was that it was a systematic review. Before you do a systematic review, it should be registered in Prospero.
Okay, ma'am.
And I didn't understand the PCOS very well here.
Sorry, ma'am?
I didn't understand your PCOS very well. That is the population intervention control and outcome and the summary that you have for the systematic review. Can you explain it to me once again, please?
Oh, 1 second, ma'am. Again, share my screen. Ma'am, just give me 1 minute. I'm again sharing my screen.
You can tell it to me verbally also.
Ma'am, this was my inclusion criteria. I have only focused on the articles that included the physiotherapy management of the benign paroxysmal position of vertigo, and the articles that specifically focused on Brander of exercises. Means Brander of exercises alone or in combination with
What was
other.
the population?
What was the population? Ma'am, the patients which were having the posterior canal BPPV.
Diagnosed by?
Diagnosed by any neurophysician, neurosurgeon, or ENT specialist.
And your intervention was only kind of studies then?
Sorry, ma'am?
Your intervention was only the branded exercises they were being.
Yes, ma'am.
Alone?
Yes, ma'am. No. Alone or in combination with other repositioning maneuvers or habituation exercises. The studies were included which either included the Brander of exercises alone or Brander of exercises in combination with repositioning maneuvers or habituation exercises. Like Cothron-Cooksey exercises, one study is there I have included in this.
Okay, now you also talked about using Scholar as a search engine, but Google Scholar is not a search engine. Google Scholar is not considered to be an academic search engine. So you have actually taken, when you're talking about a systematic review, you should be taking at least 5 search engines at a time. But I think you've taken only one, out of which PubMed and Cochrane are the only 2 search engines that you've taken.
Yes, ma'am.
What was the effect size of your studies? Because in systematic review, you have to come up with an effect size.
Sorry, ma'am.
That you did not calculate the effect sizes.
No.
So how did you conclude about effectivity in each study? Because I didn't find any conclusions there. As ma'am earlier rightly said, that you've talked about each article separately, but the purpose of a systematic review is to combine them together to give us a single result. I didn't get that single result because probably the effect size was not calculated and your outcome measures were not very well defined. So a table would have been a good idea here to conclude your things further.
Okay, ma'am, I will take care.
That's all from mine. Thank you.
Thank you, ma'am.
Thank you, ma'am. I would like to announce one statement. We have Sandhya Sahai with us. Ma'am, can you identify yourself because we don't have any entry to the name of Sandhya? Yes, Sandhya Sahai. Are you able to hear me?
Yes, sir.
Can you identify yourself?
Sir, I'm from CSJMU University.
What's your registration code?
Sir, 1 minute.
Please take my number and give me a call.
Okay, sir.
I'm typing my number in the chat box. And then I'll be removing you. I'll call you. You will call me and then we'll add you. Okay?
Okay, sir.
Sorry for the disruption. We'll continue with the next presenter.
So our last presenter for the session with code BCIPCON/S/10 with abstract photobiomodulation therapy in traumatic brain injury.
Good morning to all. My screen is visible?
Morning, sir. Yes, sir.
Okay. So, can I start?
Yes, sir.
Okay. So, I'm going to present a paper on the topic photobiomodulation therapy in traumatic brain injury patients. This is a scoping review of on the photobiomodulation therapy. So first of all, introduction, the traumatic brain injury is a major health and socioeconomic problem throughout the world. And it is affecting approximately 2 million of the population and with the 56,000 deaths among the US population and lead the permanent neurological impairment. So the basic physiology behind this is cellular and physiologic disturbances, and it is causing an increased neuronal cell death and leading to enlargement in infarct size and also affect the cognitive functions also. Because the head injury is basically affected with the normal, it leads the primary involvement in the brain structures, but the secondary involvement is related to the sensory, motor, and the cognitive performances of the patients. So the photobiomodulation, that is also known as a light therapy, has been used in various clinical conditions such as in stroke patients, in a musculoskeletal and as well as the neurological populations also has been widely used. In neurological population, it has been commonly used in stroke patients, spinal cord injury patients, and also in the head injury patients are used. So it is basically have beneficial effects on brain damage by improving the damage by improving the mitochondrial functions, and it basically inhibit the neuronal apoptosis and reduces the neuronal excitotoxicity, and increases the protein regenesis and the mitochondrial activity, so that the glutamate release and protective factors can be upregulated. So the need of this study was uh, like practitioner needs to information for the appropriate applications of the laser therapy and the dose parameters that likely to affect the outcomes that have been in head injury patients. So our aim and objective of the study was to identify and synthesize literature on the doses variables on the efficacy of basically low level laser therapy for traumatic head injury conditions. So coming to the methodology section, we have used for the scoping review ARCSI and O'Malley framework for reviewing the available studies on the laser therapy. And we have followed all the 5 steps. The step 1 was to identify the research questions. We have identified the laser therapy procedures and dosage parameters to be used. And step 2, we have identified the relevant studies from the electronic database searches, the PubMed, Scopus, and Cochrane library. In step 3, we have eliminated the studies based on our inclusion and exclusion criteria. And in step 4, we have charted out the data and interpreted the qualitative aspects of the data. And in step 5, we have summarized, collected, and reported the results based on the available studies. So coming to the step 1, our research question was like, what is the state of the current primary research literature on photobiomodulations for patients with head injury? And which targeted area have been treated to treat the head injury patients with the laser therapy, and what are the sessions, how many treatment sessions have been used in the available studies, and was it given with the sole intervention or with the combination of the other interventions? So these were our research questions. In step 2, we have searched the articles from PubMed, Scopus, and Cochrane from inception to till date, April 2022. And we have used the keywords with the laser therapy and head injury, photobiomodulation and brain injury, and laser therapy or photobiomodulation, low level laser therapy, and head injuries. So these are my inclusion and exclusion criteria. We have included the studies only with the laser interventions combined with any medications or any other interventions. And we have included only experimental studies, randomized control trials, and also we have included the case reports. We have excluded all the reviews, abstracts, and the conference papers, and the laser therapy that is not specified in the title or the abstract we have excluded, and the studies who are other than English language we have excluded from the study selections. So next we have charted the data with the author details, title, year of publication, study designs, and the number of studies, number of subjects, those according to the inclusion and exclusion criteria. And we have summarized the results with the, we have found with the key term in PubMed 9 studies, and in Cochrane we have found 5 studies. The outcomes which have been used to include in this study are the cognitions, the symptoms associated with headache, anxiety, concentrations, and river mid post concussion symptoms. So our results of the studies where we have included only 3 studies based on our inclusion and exclusion criteria. That was 2 RCTs and 1 case report studies. Overall, in RCTs, in one case report, there was a duration of 8 weeks they have followed, and they have worked on the headaches, mild anxiety, and concentration symptoms. Their findings suggested that they have found with the MRI diagnosis also, like increased brain volume and functional connectivity and cerebral perfusion after the application of 810 nanometer light pulsing with the 240 joule for 20 minutes of the laser therapy interventions. And the second RCT, which has been done by Gabriela et al. In 2020, that was done on 68 patients with the moderate TBI patients, and they have assessed the outcomes related to river mid post concussion symptom questionnaire that include only 13 symptoms on based on the sleep problems, physical activities, and many psychological problems also, and cognitive functions also. They have used a comparison group with the sham LLT, low-level laser therapy, and their findings suggested that the outcomes were improved in all the patients and did not produce any adverse events among the included patients. And the last study, which was done in 2022 by the Ronaldo Santizo, that is also a randomized clinical trial that was done on the population mild TBI patients with the 35 patients with the mild TBI, and they have given the intervention of 4 weeks and worked on the outcomes like verbal memory, visual memory, motor skills, reaction time, and impulse control. And their findings suggested that all patients improved clinically after the photobiomodulation therapy, and their post-injury outcomes were also improved. So our findings suggested that the availability of literature-based evidences for different doses on the outcomes were with the various heterogeneity, and we have found that 3 to 6 joule have been reported to be clinically effective, and the wavelength has been used 810 to 840 nanometer, and the mean doses of 240 to 9 joules for 10 to 20 minutes are reported as optimal. And basically, laser therapy is known to boost metabolism and accelerate blood circulation, and results in the reabsorption of stored tissue and rapid elimination of exudates. So this study provides possible interventions that can be used for the head injury patients also for various outcomes. But the various heterogeneity of reported doses preclude the synthesis of sufficient evidence so that it can improve or improve outcomes can be there. And based on the current literature, doses variables for the efficacy of low-level laser therapy patients are uncertain at this time. And further more studies and systematic review on this topic has to be done. Thank you. Yes, any questions here?
Yes, sir. Suvya ma'am, Bhavna ma'am, any questions?
I have only one question, that why did you call it a scoping review?
Because we have used a specific method of analysis of the results. That's why we are using scoping.
Scoping review is usually built upon it's a type of a narrative review where a baseline is being built up to find out the lacuna which is available in the study. Or it is basically trying to tell you what scopes are available after the end of the review, which I did not find here.
Okay.
Scoping review is not involved with any kind of a statistical involvement, statistical evaluation at all, rather.
No, we have not included. Yeah, we have not included the statistical value. We have just founded out the articles with the search strategies and analyzed those results. Analyze what they have done and what they are lacking, and we have reported those things.
Okay, that's all from mine.
Thank you.
Bhavna ma'am, do you have any questions? Bhavna ma'am?
I think Bhavna ma'am is having a technical issue, so we'll wait for a minute for ma'am to be audible. Bhavna ma'am, can you hear me?
to technical issues, Bhavna ma'am couldn't join. So I would like to conclude this session. Thank you, judges, for joining the event and sharing your deep thoughts and suggestions about various research presentations. Thank you, everyone, for such informative and well-thought research presentations. Results will be declared on 16th April 2020 in the valedictory ceremony. Sir, can you please stop sharing your screen?
Yes, sorry.
Yes.
Thank you.
Thank you so much, sir. Bhavna ma'am, are you trying to say something? You are mute actually. Ma'am, you are still not audible. No, ma'am.
So thank you for inviting us as a jury member for senior scientific paper presentation, and it was good to participate. And I'm really sorry that in the last presentation I was not able to participate due to some urgent work I had at home. I'll give my result discussing with the other jury member.
Thank you so much, ma'am, for joining. Thank you so much, Zubia ma'am, for joining the event.
Thank you so much for having me here. It was indeed an honor to be a part of this nice conference that you organized, and I see that you put in a lot of effort in organizing this conference. And all the best to all the participants over here. It doesn't matter whether you win or you lose, or the first prize, second prize. You all have done a good job, and keep up the good work. That's all from me. Thank you.
Thank you so much, ma'am.
Thank you, ma'am. We have been blessed to have you here, and I thank all the participants also. We'll be having our conference sessions tomorrow, that is on 15th and 16th, and our speakers will be there to enlighten us about our title, that is on traumatic brain injury. Thank you, all of you. Now I'll be ending the meeting. Thank you very much.
Thank you so much. Thank you, everyone.